My name's Carly Baker, and I'd like to talk to you about very basic lung scanning. This particular talk was written for the registrars at the PICU in Queensland Children's Hospital, where I've just spent a marvellous 2 weeks observing some amazing things. At any rate, this talk therefore will be a little bit aimed more towards paediatric lung scanning. Usually I talk about 5 different signs, but I wanted especially to tie this to some particular memory aids. So I've reduced it to 4 different signs, and I think with some fairly reasonable logic behind it. At any rate, when I talk about bedside ultrasound, I liken it to climbing up Mount Fuji. Now, you'll certainly get a better picture of Mount Fuji if you take a photograph from a long way away. And if you send that photograph to an expert, he'll be able to tell you some amazing facts that he can see. But the information that we get from that expert, in this case the radiologist, is very different from the information you get yourself when you trudge up the mountain. You often can't see very far ahead. It's pretty foggy and cold, but you will feel the gravel under your feet and you'll smell the smells and talk to the folks along the way. So really, when we look at bedside ultrasound, it is complementary to radiology. It will never take the place of radiology. In my books, bedside ultrasound is part of the examination. Now, it's really hard to put new information into your head when you've already got it stuffed so full of med school facts. It's easier to hold on to information if you can peg it up on some structure that's already there. Please forgive me if you're not Australian born, but any of you in Australia born since 1966 will probably be familiar with this incredibly iconic children's TV show. And we're going to use this as our memory aid. This is the 1966 version.
And a chair as well. There are people with games and stories to tell. Open wide, come inside. It's play school.
So that's it. That's what I'm going to hang these next few facts upon. And every time you're trying to remember lung ultrasound for children, I want you to think about a house with 4 windows. Now, we were told in the very first window on the top left that there was a bear in there. And we were told that you couldn't look in with ultrasound because of the air. But very clever French intensivist called Daniel Lichtenstein said to himself, well, even if I can't see into the window, surely I can derive some information about the lung simply by looking at the surface of the window. If the window, or the surface, or the pleura, is extremely smooth and straight and shiny, it reflects everything from the outside. You'll see shadows and you'll see reflections, but you won't see inside. And that's perfectly normal. Now, the opposite of this is when the surface is wrinkled or rumpled, and then it sparkles. And that's about all there is to lung ultrasound. If something is inside the window, but it touches the surface of the window, then you can see it. But if something underneath doesn't touch the surface of the window, then you'll have no idea what's in there. Now, when I introduce people to lung ultrasound, I say it's really like an EFAST that the surgeons do on the belly, but it's done above the diaphragm. And all it shows is extra lung density, nothing more. It does give you a rough surface distribution, however, and when you plot this all out, you can get a rough quantification of how much extra density you're dealing with. But as I keep hammering home time and time again, it doesn't tell you exactly what you're dealing with, and it doesn't tell you how long the extra density has been there. However, if you do want to move on to multi-system scanning, you can infer some of these things. Now, do you ever bother if you already have a chest x-ray? Are there any times where a chest x-ray is going to be not good enough? Well, yeah, a supine chest x-ray can miss small pneumothoraces, and it certainly miss small pleural effusions. So those are 2 times when your lung ultrasound is much more useful. The things I like to say about lung ultrasound is it's got an increased sensitivity. We can see things that we wouldn't be good enough to hear. Now, at the moment, we don't know what to do with all of these things. It's a bit like getting a high sensitivity troponin and then having to reset your normals. But what we are finding is that we can measure these things. We can count them or literally measure the size of them, and we can save them and we can audit them and we can compare them. So all of a sudden, we're becoming accountable for the things that we've just sort of done with a stethoscope in the past. Now, please, again, not to belabor a point, ultrasound is making some predictions about a deep space from some very rudimentary returning signals. It's a bit like astronomy, except occasionally we can autopsy our patients. Now, in most of the literature, you'll see that there are arguments about how we label the regions of the chest. It's pretty standard to divide the chest into the anterior chest, and then at the anterior axillary line to the posterior axillary line, we call this the lateral chest. One of the most common protocols divides the upper anterior chest as region 1, the lower anterior chest is region 2, upper axilla is region 3, lower axilla is region 4. The back of the chest is a bit, something we all argue about, but one of the most common ones calls the area between the scapula and the spine, region 5, and underneath the scapula is region 6. Now you'll notice I've drawn a curved line roughly at the nipple because when you lie an adult down, the lungs rarely go below the nipple. It's similar in children too, unless you have a hyperexpanded asthmatic. And don't forget the cardiologists, bless their souls, turn the patient completely the other way around. They like to put the patient's head on the screen right. This is not something that general sonographers ever do. So if you see someone using a cardiac probe, expect everything to be upside down. Now, in my books these days, the stethoscope is only useful for wheeze. Everything else has an equivalent with an ultrasound, and when you learn what the equivalent sign is with the ultrasound, you can simply use those signs and put them back into the old diagnostic paradigms that you learnt when you're a medical student. For example, normal breath sounds will give us a pattern that we call sliding with A lines. Crackles will give us a pattern that we call B lines, and I'm going to subdivide these into wet and dry B lines. Dullness, which was always the bane of my life, I could never pick dullness from stony dullness, is now easy to see if it touches the surface, and we can measure consolidation quite nicely. And finally, stony dullness, something that was well beyond me in my medical student years, is something that ultrasound is very good at and can give a lot more information than even a CT scan. Warning though, ultrasound will never show the hilum, so conditions that are predominantly perihilar, and for example, endotracheal tube placement, will not show up on your lung scan anywhere near as well as they will show on your chest x-ray. So how do we do it? I tell people just put the ultrasound probe where you'd normally put your stethoscope. If you're in a rush and you're just trying to admit a patient to the orthopedic wards, you often just throw the stethoscope on one side and then the other. If you're in a trauma situation, you probably just want to listen to the highest point for a pneumothorax and the lowest point for a hemothorax. But if you're trying to find a pneumonia, you've got to spend a lot more time listening to a lot more areas. Now I'm going to divide our signs into 4, and I want you to put each of these signs in one of those 4 windows of the play school house. And the top left window, the bear in there, we're going to call the A pattern. A pattern, unfortunately, is out of fashion because it's a default normal. Anything can have an A pattern. But what we're really looking for, that's really more important, is that line slides. So what we're going to do is we're going to sling the ultrasound probe, any of them in fact, doesn't matter which one, longitudinally so that we've got a rib at each end of the probe. Those ribs will give a bright leading edge and then a black shadow underneath. And they really act like stepping stones, because if you step down off the leading edge of the rib 5 millimeters below should be that white line that moves side to side. Now, if you're exactly at right angles to the surface of the lung, it's not always as easy as you say, it should cause a reflection, which will cause that second white line an exact multiple distance deeper, which is a little bit less prominent. And then if it's a really shiny flat surface and you're perfectly at right angles to it, you might even see a third line repeated 3 times the distance below. We call this the A pattern, but it's the sliding that's more important. If you have a look at on this picture, we've got a big rib shadow right down the middle. And if you watch carefully, you'll see that that rib's moving up and down as the patient breathes. But if you look 5 millimeters below the leading edge of that rib, you'll see that bright white line interrupted by the shadow. And if you look at it very closely, you'll see it's a bit more alive than the tissues just above it. It flickers or scintillates. That's what we call sliding. Sometimes we call it marching ants. Sometimes it's just a bit like a couple of pixels clapping. And I always say it's one of the hardest signs because actually you have to look very closely in some patients to see that it's really there. Sliding tells us that there is expanded lung in this part of the chest. Now, if you use different probes, we get different shaped pictures. And I always try and get that pleural line roughly a quarter of the way down the screen. Explain that later. But the picture on the left, we have a cardiac probe. It's got a small footprint, so it sits between the ribs, and we don't see the ribs as clearly. There's one either side of this picture. But if you look very closely, a quarter of the way down, that bright white line that just has a bit more life and a bit more slide than the lines above it. That's the pleural line. And the picture on the right is the same thing, but it's with a straight or linear probe. That gives us a lot more detail. It's a shallow probe. And you can even see tiny little irregularities on the lung surface causing those little smudgy icicles that slide side to side, and even one beeline. Now again, with this little linear probe, it's too small to even get 2 ribs in the picture, but we are seeing 1 rib off to the screen right here. Now, please don't be worried about the different pictures because although the pictures look different, the signs are relatively robust in that if there's a beeline, we're going to see it with a cardiac probe or a straight probe or a curvilinear probe. Maybe one more beeline with the cardiac probe might be a little more indistinct with the linear probe, but if you get used to whatever probe you're using, obvious conditions will be obvious. So, sliding with A lines, what does that mean? It means that we've got normal breath sounds. It means that there's no pneumothorax at this point where we're looking right now. Unfortunately, the opposite is not true. It doesn't mean if that we don't have sliding that we do have a pneumothorax, because unfortunately there are several conditions that cause loss of sliding. Sliding is important, but it's something that I'd like to go in a little bit more depth at the end of this talk. It's the hardest sign. Oh, I did give you a couple of examples though. On the right, you can see a bit of straight pleura that is essentially dead. There's no sliding. On the left, you can see where I've got written the word lung, how there's a sort of an indistinct curtain coming across. That's what we call a lung point. A lot of people think that there will be a gap or a break between lung and pneumothorax, but there isn't. It's white sliding into white. This is an example of a pneumothorax with a straight probe. We've got a rib on the right. It's even got its own A line underneath it. A rib on the left. And right in the middle of the picture, a bright white line. If you look very closely at that bright white line, you'll notice that the fascia above it are reflected dimly underneath it. So each of the lines that you see deep to that pleura has an origin above. Here's another example of the A pattern. It can be quite distinct in very thin elderly patients with COPD, but something like this, as you can see, it comes and goes. It doesn't slide with movement. I used to like the old terminology A pattern because you could say it stood for air, asthma, and anything at right angles. And I want you to tuck that A pattern, that horizontal sliding pattern, into that first window in the house, top left-hand corner. There's a bear in there. Well, we're going to change that to there's air in there. But now it's time to move on to the second window on the top of the house. There's a chair as well, and I like that picture in the head because the chair that we used to see back in 1966 had many spokes to it, very like the B lines. Now this time when we look at those two ribs and we look at the pleural line underneath, the pleural line has white, we used to call them comet tails or rockets, that attach to it and sweep. In the old days they'd go right to the bottom of the screen, but with our new machines that try and help us by getting rid of all of the artifacts, sometimes these B lines don't quite reach the bottom of the screen. For me, so long as they go at least halfway down, I'm happy. Now, one beeline between friends is quite normal. You may see a beeline at a fissure, but 3 beelines in any one picture is really starting to get a bit beyond normal. We'd assume that if you had an extra good stethoscope, you'd hear crackles just there. Now, crackles mean just the same with ultrasound as they do with a stethoscope. In other words, it could be all sorts of things. It just means there's a little bit more density, such as fluid or inflammatory cells or even fibrin, in either the alveolus or the interstitium. This is what it looks like with a straight probe. You'll notice how those lines obliterate the A lines while they're there. Now, we often divide these sorts of B lines into two sorts. Soldati, one of the Italians, I think, first made the suggestion. I like it very much. We call wet B lines the lines that come from a beautifully straight, smooth pleura. And they're very sort of transient things. If you change the patient's position, the B lines may move. They'll tend to be dependent. If you treat them with diuretics or with positive pressure ventilation, they may well go away within 10 minutes of appropriate treatment. And they don't leave anything behind. They can leave behind a beautifully smooth pleura. This is the sort of thing that you get with pulmonary edema. You'll also get it with pulmonary contusions. You'll get it at the edges of pneumonias, perhaps due to lymphatic engorgement. Sometimes it's fairly subtle like this, and you're stuck wondering if they're really 3 at once. But other times it's very obvious and the B lines become confluent, such as it's pretty much white right down to the bottom of the screen. White to the bottom of the screen is quite abnormal if you're talking lungs. In normal lungs, what will happen is that the beam attenuation will mean that the bottom of the screen should actually be very dark. Dry B lines are the other sort. They're what you see where there's some sort of pathology or pathological process affecting the pleural surface. So the pleural surface, instead of being flat and shiny, is rumpled and thickened. This means the pleural surface will never create an A line underneath it, but it often has your B lines hanging off it. This is your classic COVID pattern, classic lung fibrosis. In fact, any interstitial pneumonitis could cause this pattern, as can lung contusion. It could be something that's relatively transient. If you treat it with steroids or with antibiotics or just a good immune system, it may go away. Or if it's like fibrosing lung disease, it may be permanent stay. It's not something you're going to change with diuretics and position. Now, just occasionally, you'll also see very small divots in the lung surface, miniature consolidations less than a centimetre in size. They often have a very bright B line deep to them as well, so they stand out even more. And these little divots are what we call subpleural consolidations. They're a sign that of a reticular nodular process. They're the sort of thing that you might see in atypical pneumonias if they're localized. You might see them in COVID if they're patchy. You might also see them in miliary TB or miliary staph or even disseminated malignancy. They're certainly much slower to shift with treatment. So I want you to put these two packages or these two patterns in that window in the top right-hand corner of the house. You might want to consider them like the smooth chiffon curtains or the crinkly lace curtains. You can see through them, but I must reinforce both these top windows are what we call artifacts. We're not seeing real lung tissue in either of these. Just a couple more examples. The pleural surface on the left you can see is really crinkly. It also has B lines, but they're not going to shift with a diuretic. But on the right, you would be forgiven for thinking that this was a simple pulmonary edema until you look more closely and you see that the pleural line actually looks a bit moth-eaten. If we look up close, and this is a straight probe, so you've got a great view of the pleura, you've got a rib on the left. It's almost like a bit of fluffy white cloud moving under the pleura. It's moth-eaten or fragmented. This is pleural line abnormality. Now, any of these things in the top right-hand window we call bad, bubbly, or boggy. Now it's time to move down to the third window. There are people with games, I think. And for the first time, we're actually going to look into the window because we're going to imagine all the folk in window number 3 have got their noses pressed up against the wall and we can see them. And so what happens is that smooth reflective surface is now interrupted, and what we actually see in the lung is real. Now it'll still move with respiration. It's usually called tissue-like or hepatization. It'll be bigger than a centimeter in size. That was the cutoff. The deep margin is quite important. It may be a fluffy white cloud that we call a shred sign, or it might be a smooth, expanded cannonball type pattern. Please take notice of the deep margin. And also look inside the consolidation because there may well be some white flecks or some dark flecks. The white flecks are often air bronchograms. That may be single dots or branching tree-like structure. You can also get fluid bronchograms, which give you another branching tree-like structure. Now, here's some examples. Consolidation in children is almost always bacterial pneumonia. Note those lovely air bronchograms there. But in adults, you have to also add into your differential diagnosis malignancy, infarction, and perhaps even severe pulmonary hemorrhage. Now you'll notice if we have consolidation that the volume of the lung is pretty much preserved. That's because we've got cells infiltrating. It's not a simple collapse and resorption. If you put colour flow on and stop the patient breathing, you may well see a vascular tree within there. And you'll also notice that it doesn't have particularly much movement. It slides a bit, but it doesn't expand and contract because it's already engorged. Here's a couple of more examples. A small consolidation on the left where really more what we're seeing is the bright fluffy white shred sign underneath it. On the right though, we've got a very large consolidation in the left lower lobe, just beside the heart. And you can see the branching tree-like structure of air bronchograms, which of course come or radiate out from the hilar region. That's a complete lobar pneumonia, that one. Here's another one close up where we can see the fluffy white shred sign diagonally across the middle of the screen. We can see what looks like a dynamic air bronchogram just above that. But notice how we can actually see tissue there. It looks a bit stiff, and if you weren't sure, you could be forgiven for thinking that this was a piece of liver and we were looking at gas in the stomach underneath it. It looks very similar. And here's another one. See that little spot of lung on the far left of the screen where we still have air in the lung surface, but then consolidated region to the side. Now you'll notice, if we look at the scale on the right, this is actually a very small area, perhaps 1.5 centimeters at the most. We're not exactly sure what to do with these very small consolidations that we can now find. It's an area that's ripe for further research. Here's another stiff consolidation. Again, no loss of volume. This one, on the other hand, this is atelectasis. You can see how the lung expands beautifully with each breath in that effusion. And here again, another huge consolidation. We've got the diaphragm pretty much down the middle of the screen. We've got the liver and kidney on the screen right. And what's interesting in this picture is how we can see the spine continuing up into the thorax. That's an unusual thing to see. You'll only see the spine if there's no air at all between you or the probe and the spine. So that means to us that there's an entire lobar consolidation. You can certainly see a starry sky of many the white spots in between of air bronchograms, but see that spine continuing above the diaphragm. Big warning sign. Here's another subtle consolidation at the top, nowhere near as clear. And a quick word about atelectasis. Atelectasis loses volume. The lung becomes very mobile and can give you some very odd and amazing shapes occurring within the effusions. I liken it to fronds of seaweed waving about in an effusion when you look at atelectatic lung. Blood clot moves freely as well, got to warn you. Now just be wary of thymus. Thymus does look for all the world like consolidation. I mean, it is consolidation. But remember, it will be midline, quite mobile, and also notice how it has a very even white stippling within it. We don't have the branching tree-like air bronchograms. You'll pick thymus simply from its position, and you get used to this sort of granular look to it as well. Also, thymus never has the fluffy white shred sign underneath it. So I want to move to the fourth window now. We've had top left window was the sliding with the A pattern, the shiny surface of a beautifully clean window. Top right-hand window was the B pattern, where we had the curtains, either the smooth chiffon curtains or the lumpy, bumpy, lacy curtains, wet crackles and dry crackles. The third window on the bottom floor was the one with all the people with their faces pressed against the window. We actually see inside what's going on. Now the fourth window down on the right-hand side, we're going to talk about effusions. Ultrasound rules effusions. You don't look just at the effusion, you look through the effusion. You look how things behave within the effusion. Lichtenstein in the old days called it the quad sign because what he saw was the darkness of the rib shadows crossed by the darkness of the fluid. And what would happen was the lung within the fluid would move very easily as it expanded and contracted with breathing, like this. And it's really important to watch how lung moves, because if the effusion is thin, a transudate like this, for example, the lung tissue waves very freely in it with respiration. This is only very small effusion, but see how the lung moves so freely within. Diaphragm on the screen right and a nasty rib shadow in the middle. Now effusions can be very big and you've got to enjoy them. You have a good look at the diaphragm. Sometimes you can have a look at the vessels on the far side, and you have a look at the sort of tissue waving within it. This particular bit of lung here isn't moving terribly freely, not like seaweed, so I would think that this is a degree of consolidation here. You also then turn the gain up on the effusion because we want to see if there's any little particles actually floating in it. Here's a bit of atelectatic lung waving freely, but if you look in the center of the picture, just above that, you'll notice there's a sludgy swirl of tiny particles. That's a plankton sign, as Lichtenstein used to call it, highly suggestive that this effusion here is probably an exudate rather than a transudate. Now, sometimes you can see all sorts of things. You can see an adenocarcinoma deposit at the bottom of this lung here. You can see how it's thickening the diaphragm. You can even see tiny flecks of malignant cells floating around near those fibrin strands. Sometimes you'll see delicate loculations like this resolving hematoma, I think was. And sometimes you'll see really solid scarred loculations which won't shift without decortication or a lot of TPA. We have the diaphragm in the middle here, the spleen on the screen right, and the lung on the left of the picture with some very tense loculations. Now here's one lucky last trap for new players. It looks for all the world like an effusion. I mean, it's black. But there are a few things here that should set up your warning signs, your spider sense. We can see it's in region 1, the top of the lungs. That's not a normal place for an effusion. An effusion tends to obey gravity. You'll also see that it's pushing the chest wall up, and that's an odd thing. Effusions don't tend to deform the chest wall, not without collapsing the lung completely. You'll also notice that the lung here is not waving freely. It seems to be a bit stiff and stuck and very irregular base. I'm showing you this not because it's common in children, but it's not uncommon in adults. This is a mesothelioma. In fact, pleural plaques do tend to be black. They're odd things. They look like localized small effusions, but you won't get anything out if you put a needle in these. When they become malignant, they chew down into the lung surface like this. So, in summary, when you think of lung scanning, I want you to picture this house in your head. The top left, we have the air in there. We're going to see and watch the sliding of the pleural surface about a quarter of the way down the picture. I say a quarter of the way down because people are all different sizes. There's no point me saying set your depth to 12 centimeters when you're scanning a neonate. The top right-hand picture, we're going to have the curtains. They might be chiffon curtains or they might be crinkly lace curtains. They'll slide like that. The third window will have real things inside. We'll still have sliding. And the fourth window will be our effusions. We're going to enjoy the effusions. We're going to watch how the lung moves within the effusion, look if there's any floaty bits, and look through the effusion at the structures on the other side. But that's not enough. Sorry. But it's okay. You're already quite used to taking this further. This is what you do every day when you throw a stethoscope around someone's chest. What you do is you plot the pattern of the patterns and you use some Bayesian updating to your pre-test probability. So just say I scanned the front, the side and the back of my patient's right lung, and I've stuck them here on the screen left, just like it's a chest x-ray. And then I scanned the front, the side and the back of their left lung. I stuck them on the screen right here, just as if you're looking at a chest x-ray. And if we saw a picture like this, imagine it's all sliding, I ask you, what would it sound like? It would sound like normal sliding. And if this patient was dyspneic, I said to you, well, what's your differential diagnosis of this pattern? I hope by now you'd say, well, it could be normal, could be asthma, although we can't see a wheeze with our ultrasound. It could in fact be something entirely different like DKA, or a PE, because the PE may not necessarily affect the surface of the lung. Now, if we saw a pattern like this, where the top of both sides sounded normal, the sides both sounded a bit crackly, and the bases sounded dull. This pattern's interesting. It's symmetrical. There's sort of a degree of gravity gradient, so it starts dry, gets a bit wet, and then gets very wet. And it's the same on both sides. This would be very consistent with subacute or resolving pulmonary edema. If we had a pattern like this, where we had localized change, just consolidation and effusion down the right base, with a few peri-consolidation B lines, we'd say to ourselves, in a child, most likely pneumonia. In an adult, though, who tend to have more things wrong with them, it could also be a malignancy, or it could be a pulmonary infarct. If we had a pattern like this, where it's dry and then it's crackly and then it's dry again on the left in the patient's right, and then on our right, patient's left, we have crackles, dry, and then consolidation. Think to yourself, this is weird. This is patchy. It's asymmetrical. It's discontiguous. You could certainly say this is COVID and be quite right, or highly likely in certain circumstances. Or you can say, what other conditions cause patchy, asymmetrical, discontiguous conditions, such as any of your multilobar atypical pneumonias, or even ARDS-like patterns. Anyway, it's time to get back to pneumothorax because I did promise we'd look at it a little bit more. When we use lung ultrasound for pneumothorax, we are unfortunately making a couple of assumptions that can catch you out if you're not aware of them. We're assuming that the air is going to rise to the highest point of the chest, and that's pretty good unless you're in a respiratory ward. And once you're in a respiratory ward where people have had pre-existing lung conditions, all bets are off. The second thing we're assuming is that the lung is being ventilated, or at least the bit that we're looking at is being ventilated. That's not always the case if, for example, you've got bullous lung disease. And finally, we're assuming that the lung will be moving more than the chest wall. And that's a good assumption until the patient gets very dyspneic, in which case it can be hard to tell the difference. So there are a couple of confounders to our well-reasoned logic. Pleurodesis is going to throw us right off. So whether it be iatrogenic pleurodesis or pathological pleurodesis, it's going to stop air rising to the highest point. Secondly, bulla won't necessarily expand, and it can be very, very hard to see sliding in a bulla. And finally, as I said, when the patient is really breathless themselves, or if you yourself move your hand too much, it can be hard to decide whether there's extra lung sliding at the pleural line. Don't panic though, there are a couple get out of jail cards, things that you can use to decide whether there's a pneumothorax or not. The first thing is a thing called lung pulse. Lung pulse is the transmission of cardiac pulsation movement through expanded lung. So even if you don't see sliding, you may in fact see a regular beat happening, a tiny jerk of movement in time with the heartbeat. This tells you you've got intact expanded lung between your probe and the heart. Get out of jail card number 2 is any moving B or Z line. Z lines occasionally used to describe those tiny little pleural line abnormalities that don't reach the bottom of the screen. We're not quite sure what to do with. Any single tiny one of these, as long as it's moving, tells you that we've got intact lung at this point. And finally, a lung point. Lung point takes a bit of hunting. It's a good sign in that it's 100% specific for pneumothorax. It's a bad sign in that it takes a long time to find and it won't be present in all pneumothoraces, because if your lung is completely collapsed and not touching the surface of the pleura at all, not touching the parietal pleura at all, you won't find a lung point. And I don't want you to spend an hour searching for it. So here's some examples. I'd say to you, is this sliding here? There's certainly a lot of movement. is not helped by the fact that the sonographer, that was me, is moving their hand too much. Now, I'm fairly suspicious that this is in fact pleurodesis because I've got it in my file that says pleurodesis. But anyone looking at this picture will say, get me a better view without with the probe held still. How about this one? I did hold my hand still on this one. This is a patient with chronic bullous lung disease, and I think that this is some pleurodesis at the apex. In fact, I know it's a degree of pleurodesis at the apex. Really not exactly sure what was going on. Same patient a bit further down and around. It's very hard to tell if there's any sliding at all, except we are seeing that tiny little defect in the pleural surface there. And finally, this one. As you can see, this is one of those lung points right in the middle of the screen. We've got sliding lung to the screen right, and we've got pneumothorax to the screen left. Here's another lung point, but in this case we've got the sliding lung on the left of the screen and the pneumothorax to the right. As I've said before, there's no break, there's no line between the pneumothorax and the sliding lung. It is subtle. You've got to look closely for it. Here's another one. This is an odd one. You might think we've got sliding and B lines on the screen right, but if you look at it really closely, you'll see that it's probably not sliding so much as being pushed aside. We've got fluid and hemorrhage off to the screen left, and as the patient breathes, it's pushing the free air out of the way. This is the hydropoint. It's what we see in a hemopneumothorax or a hydropneumothorax. And one thing to be wary of, to be scared of, is when you see one of these tiny B lines that is fixed, that doesn't slide side to side. Please do not put a needle in anywhere near this. It's probably a bit of tethered lung scar or scarred lung, but it doesn't tell you that there's intact or expanded lung here. So in summary, I don't want you to take my word for it. There are a few really good review papers now, and I like papers that aren't written by the sonologists. I think finally when the general specialists start using lung ultrasound and start approving of lung ultrasound, that we've really made it to the big time. This is a very useful guideline. I also think you should keep an eye out for the Antiultrasound papers because they really tell you where the problems are. And this is a great paper. It's by a paediatric radiologist who finally, I think we've really made it, I love this paper, says that lung ultrasound is a useful thing, but should be done by paediatric radiologists. But I'm so pleased that we've got even this far. So in summary, lung ultrasound, it is not hard. Just think of your house with 4 windows and think of the old descriptive patterns you used with your ultrasound, with your stethoscope, and then translate the pictures you see into the old diagnostic paradigms, because it's easy to get the pictures, but you still have to turn your brain on to work out what they mean in each particular patient. Thank you. Please enjoy.